Welcome, everyone. Good day to everyone. We have an interesting chat today with Dr. LaMar Hasbrook. So we're going to go ahead and ask him some questions dealing with the pandemic because he's quite an expert on that. And but before we do that, I want to go ahead and tell you a little bit about Dr. LaMar, so you get an idea who we're listening to and who's going to give us his comments, right, about what's going on. LaMar has a long list of accomplishments and he basically achievements that are too long to mention, but I want to give you just a couple. One, he has been, I guess, a strategic advisor for the American Medical Association. He's also been CEO for the National Association, I have to read it, National Association of County and City Health Officials, which represent the nearly 3,000 health departments across the nation. He's also worked as the top doc for the state of Illinois under Pat Quinn. And something that's really interesting that obviously the reason that I really want to talk to him and chat with him is that he's got experience in training from the CDC and epidemiology. He's also been a former Epidemic Intelligence Service Fellow for the CDC, along with many other things that he's done. So I think that kind of gives us all an idea of what Dr. LaMar is all about. So without further ado, let me welcome you, Dr. LaMar.
Thank you, Frank. It's great to be with you.
Thanks. I'm very happy. I want you to know that I read not everything you write because you write a lot, but I try to and I follow you, and I'm glad you're there to give me at least some perspective on what's going on. Let's go ahead and dive into some of the questions to make this nice and sweet. We'll start with the first topic, which has to do with the testing. And I gotta be honest with you, I'm probably at zero level of what testing is. I haven't had my test for COVID. And if I were to do it, I kind of want to know more about it. So my first question is, are there different types of COVID testing?
Yes, there are. So coronavirus, novel coronavirus is a virus, as the name implies, and there's a way to test every virus if it has been seen in the human condition, and there's been a test developed. So basically the way a test is developed is to actually be specific to that particular virus. So we could not have had a test for this ever before because we've never seen this. We've never isolated the virus. That's to map out what the virus is, its DNA and those types of things, and then to develop a test that can then measure presence or absence of that virus, those particles, the DNA, in your system. So basically, the way a test is made, there's several tests as you alluded to. Two tests actually measure for the presence of the virus in your body. We call that the antigen. The antigen is the virus or the bug or the bacteria, whatever you're concerned with, or particles of it. So one test to say, oh, you have the virus in your body. The other test to say you have particles of the virus, which means also you have the virus in your body. Okay. So when you have a virus in your body, it's going to be present in certain bodily fluids, blood, urine. We're finding out tears in terms of coronavirus, obviously saliva and respiratory droplets and those types of things. So two tests measure for presence of the virus. So if you have a positive test, that means you have the virus in your body right now. It's shedding in your body, it's shedding in your mucous membranes. You have it, you're walking around with it. The third type of test measures not the antigen or the bug, but it measures your immune response to the bug. And that is your antibodies. Your antibodies, and antibodies are something that's a part of your immune system that kicks up to basically attack and clear and kill any foreign object that comes to your body. So with this test, which is typically a blood test, we're actually testing for the presence of the antibodies that are specific for the virus. So that means if you have these antibodies, you at some point in time in the past had to have been exposed to the virus or infected with the virus. Doesn't mean you have it right now. It just means that you've had it in the past. So those are two different types of tests that give you two different types of information and potentially two different types of paths forward in terms of how you address it. Obviously, If you're found to have the virus in your body, you want to do certain things. We've learned about isolating and quarantine and things like that. But if you have you have the antibodies, which shows that you had some infection in the past, that might mean you're immune. That might mean you're clear to go to work. That might mean you may not get infected again. So other things are going to happen there. So those are basically the three different types of tests. Really, the testing you for the virus, testing you for the reaction to the virus or the antibodies.
It brings up a question right away. If I get tested with the second one, which is the antibodies,
Antibodies,
right, and I don't have those yet, but can I have the virus even though I don't have antibodies?
You can, there's small windows of time. So what happens if you have the virus and then your immune system begins to react to it and it builds up antibodies and they go higher and higher and higher and higher. We call those titers. That's how we measure antibodies. So they'll go from 2 to 4 to 8 to 16 to 128, all the way up in the thousands. And by having the presence of those antibodies, you now basically have some protection. Once you can clear the virus, which will eventually leave your body, you'll still have the antibodies behind. So it really just depends on where you are with that course as the virus is leaving and the antibodies are ramping up. Where are you at that moment in time when you're being tested?
Okay, one more piggyback question on that. I asked my brother, and I said, have you been tested? He said, yes. I went to Kaiser and I got tested. And I said, well, was it free? Yeah, it was free. How many times can you get tested? As many times as I want. So then I said, well, that's really interesting. What test might he have had? Which one of those at Kaiser? Let's just say.
Yes, it depends on the turnaround time. Now, antibody tests are more frequent, more available, they're cheaper, and you get your results within a very short turnaround time, within an hour. He probably had that. You know, you can actually get that over the counter, you know, some places like LabCorp, places like that. The antigen tests, we heard about the malfunctioning of the test kits. Those are far more complicated in terms of being processed. So they can only take the sample in the hospital or in the nursing home or wherever you go. That has to be sent to a lab that has to process a lot of different things. And that normally takes 48 hours to get that one back on the short end. So kind of depends on what his turnaround window was. Probably, my guess would be it was probably an antibody test.
Right. Before we ask you about reliability of tests, I did read that the FDA approved what is called the patient at home sample collection test. And that obviously is the curiosity, just drives me crazy. What is it? Does it work? What do you think about that? Is that the better choice maybe?
Sure. So any home testing, think of it as a pregnancy test. Okay, you can actually take the pregnancy test and sample yourself. In that case, it's going to be urine, right? And wait and see that develop in front of your eyes. Okay, that's not the same exact thing, but that's a good analogy for what will happen. So if it's an antibody test that's at home, you can actually take it. And some antibody tests, most are blood tests, so you're not going to be doing that, obviously. Some are saliva tests, which you could do, but because the interpretation of the test requires a little sophistication sometimes, what most folks are going to be doing is getting their sample either from their saliva or from their mucous membranes in their nose, typically, the back of their throats, packaging it up and sending it to a place, a laboratory, where they can then look at it and test it. So really what it's doing is it's giving you convenience that you don't have to wait in a doctor's waiting room, that you don't have to go through. We had drive-through testing at one point in time. Maybe some places still have it. So it's just about convenience. Obviously, it's going to take you much longer to get that result because you got to mail it. They may give you some log-on information where you can actually see it online. So it really is about convenience. And to your other point, test accuracy is very important as well. So we can talk a little bit about that. How well can you trust the results of any test? Doesn't matter if you're taking the sample at home or if you're going into a doctor's office.
Yeah, that's kind of like the next question. I believe that multiple tests is the best the most reliable way to do it, especially if maybe one member of your family had it and the rest didn't. Obviously, you need to follow up with that. But you know, what is the real? I mean, which one of those? Obviously, antibody, antigen, or drive-through, or at home. Now we have, I think, 4 options, and that's what kind of gets someone like me confused. You know, I like the drive-through one. That sounds interesting.
Right.
But I've never done it, and I don't know what it was. I know you're supposed to cough, and apparently the virus comes up to your mouth. It's here to collect. All of the logical stuff they're saying to me, but is it reliable? You know, which one?
Well, here's the thing about tests. There's probably, as you said, there's a number of different ways to get a test. Drive through, doctor's office, walk-up lab, you know, in the hospital, those types of things. There's a number of different types of tests, and then under each type, antibody or antigen or virus test, there's a number of different manufacturers of those tests. Okay, so not one company making all the antibodies tests. There's probably 100, 200 companies making their version of the antibody test, because once you isolate that virus and you know what it is, you can get that DNA fingerprint of the virus, you can then begin to manufacture tests. But to your point, how do you trust the accuracy of the test? So every test is going to be measured for accuracy, and these brings up terms that we look towards, which are called specificity and sensitivity. So without getting too complicated, all right, a sensitivity really really gives you a measure, and it's in a percentage. So what you want, bottom line is you want a test that has both high sensitivity and high specificity. When I say high, you want it to be 80, 90% or better, 95, 98% better, or better. Yes, you want it to be at least, you know, the higher the percentage of specificity and sensitivity, the more accurate the test is. So let's just talk very briefly about what that measures. So when a test is 70% sensitive, what that means is that 70% of the time, it's going to catch everybody that has the virus. It's going to call it positive. It's the ability to capture positive tests, okay? So that means 30% are going to be missed, okay? We're only going to catch 70% of those that are positive. You have 100 people that come in, they're all positive. That test will pick up 70 of them and miss 30. That's sensitivity.
Okay.
Specificity measures the absence of the condition. So again, if you have a specificity of 90% in this example, okay, and you have 100 people walk into a room, they're all negative, the test is going to say negative for only 9 out of 10 of them, 90% of them. It's going to miss 10. So what that means is that you can have some false negatives and some false positives. You don't want that, okay? Because you don't want to be told you have positive and you actually have a false positive, which means you don't really have the virus, but the test said you did, okay? That's because the sensitivity was low. Likewise, you don't want the test to miss you and tell you that you're A-okay, you don't have the test, but because the specificity is only 60%, you're in that 40% that it missed. Now you're walking around with a false negative, infecting everybody, okay? So those are the two measures. So you want to look at measures of test accuracy. You can ask the manufacturer, probably in the insert. You can ask the person that's giving you the test. If it's an in-home test that you're administering, you can look at the information. So I would say you want something that's going to be both high on both sensitivity and specificity. You want to look for like an 80% threshold or so. Now, because of the need for these tests and the rush to make these tests, the FDA has reportedly been pretty lax. So they're not on top of it as it should be. That's why there's hundreds of manufacturers making lots of different tests.
You know, and that is why I wanted to chat with you, because that explanation is the first time I hear that. And you put it in really, really nice terms to understand. Thank you. Thank you. And I'm hoping the people that watch this get an idea. Now you could rewind and play again so you can get it down.
Yes.
Let's
the bottom line on that, Frank, bottom line is ask for the accuracy of the test.
Got it.
Look for terms, sensitivity and specificity, and the higher, the better. Okay, a perfect test is 100% sensitive and 100% specific. Okay, there's very few tests like that out there.
Got it.
Virtually none. But if you can get in the 90s, you're doing well.
if you do it in the 90s or above. That sounds great. All right, so that talks about the reliability of the test, which is a huge question for me. Let's just go ahead and talk about a little bit of a different topic now related to COVID, so of course, but not the testing. Let's talk about the vaccine. And you and I talked before when this all started, and I was a little bit scared. And I said, Lamar, is this going to get worse? You said, yeah, it'll get better, but it'll get worse for us. I'll never forget that. And you were absolutely right. And we did talk about the vaccine, and you explained a little bit to me then about how long it takes and if and why, et cetera. So maybe let's talk a little bit about that. Now, I kind of give myself, like, from this point forward, like a 12-month period. Why? Because it covers a year later and a little bit more. In those 12 months, I'm just crossing fingers because I'm ignorant to this, but do you think we could have a vaccine?
No, I do not. I do not
All right,
think we'll
next
have a
question.
vaccine.
Just kidding.
Here's a couple of things about vaccine, basic vaccinology. So getting back to the antigen, the virus, the particles of the antigen, okay? What we can do is we can take a piece of the virus, okay? We can render it inactive, kill it, okay? And then formulate it in a way that we can make a vaccine out of it. So when we inject you with that, some vaccines are nasal, but when we introduce that to your body, because you have that viral particle in there, it's not going to be harmful to you, but it will actually kick up your immune system as if you actually have the real live virus in your system. What that does is builds up your antibodies again to protect you from it, okay? So that's the process of what's going on. But two things need to happen before a vaccine can be green lit. One, it needs to be shown that it's safe. So that particle that is being used and all the stuff that is packaged with and all that kind of stuff, that has to show that it's not going to cause any harm. We don't want to be injecting people with things that's going to make them sick or cause some other side effect. So safety is important. The other thing is something called efficacy, which is essentially like effectiveness. Is it effective? So if we give it to study patients, while we're studying this over a period of 12 months, is it actually kicking up their immune system and raising those antibodies that are going to be protective, or is it just kind of bumping them up just a little bit, showing that it's responding to it, but it's not enough to give any protection? So that's something called vaccine effectiveness. And most vaccines are about 60% effective. The flu vaccine last year, 60, 70% effective, sometimes as low as 50% effective. So I say that to say that even when a vaccine is ready, and again, it has to go through this study period of 12 months plus to make sure it's safe and effective. Even when it's ready, it's not going to have effectiveness like 100%. So if I take it, I'm good. You know, it's not going to be 90%. It's not going to be 80%. It's going to be somewhere around 60, 70% or so. Meaning that everybody took it, they still wouldn't be protected 100% because it's only going to cover you for about 70%. Okay, so you can't really rush that study process, which is why I say likely it will not be ready in a year. The other thing that the audience needs to know is that vaccines, there's over hundreds of vaccine candidates, people working in different places with different pieces of the viral particle, formulating vaccines around it and testing it. So what typically happens is the first vaccine that comes out, pretty good, but in the background, people are still working to make it better. Working to make it better. So what will happen is we'll probably shift out vaccines as others prove to be more effective. The first one that hits the market might be 60% effective. The next one that hits the market might be 72% effective. So there's this race, if you will come up with the best vaccine, but it's going to take some time.
And it sounds like it may never get to 100%, but
no, it will never get to 100%. No, it will never. If a vaccine is 80% effective, that's great. That's great. Most vaccines for the seasonal flu, 60% effective, 50% effective. Important.
And that brings up another question. You have these vaccines for the seasonal flu that they take every year. So we're gonna, once we do come up with vaccine, is it gonna be the same pattern every season we take it?
No, and right now the seasonal flu differs every single year. So when the flu hits, whatever that bug, I call it all microorganisms, I just call them bugs. Sometimes they're viruses, sometimes they're bacteria. But in flu season, we're obviously talking about virus. So every year the flu vaccine is different, which is why every year you have to get a flu vaccine, because last year's vaccine is not going to protect you from the circulating flu virus the next season. So every year, most people don't even realize this, but since H1N1, which was the last global pandemic, our flu vaccine for the seasonal flu has actually included protection from H1N1. So the flu vaccine is a cocktail. Usually, when I say cocktail, it's a mixture of things, usually 3 different particles, 3 different circulating bugs. It's trying to protect you from the most likely viruses that are going to be circulating that summer or that winter. So when this flu vaccine comes out, to your point, yes, every year there will need to be revaccination for the COVID bug. In this case, the novel coronavirus.
Okay, got that, and I understand that. It's pretty much what I would guess, I guess. Let's see. The season for the flu now begins. When does it begin? Tell us when the current flu, like when we get our.
Yes. So the flu season can start as early as October, and it can go all the way to March, sometimes April. The peak of a flu season is between December and February.
During vacation, of course.
Yes.
Go figure.
That's right.
Would that be the same for COVID-19, or we don't know that?
We don't know. All bets are off. We're still learning. We don't know when it's going to hit. I can tell you that there were, with this last flu season, there were a number of folks that were sick with, some that died from COVID-19 during the flu season, because we didn't really have our act together in January and in February. It wasn't until like March, late February, March, that we actually started doing some testing. It was very, very slow ramping up. So we missed a lot of folks that would have died or been infected by COVID earlier during this flu season. There was a little bit of an overlap.
That's such good information, Dr. LaMar. I love it. This is great. Let's see. Will we have more damage during the second wave, or are we smarter now about protecting ourselves? What is your opinion on that?
I think we're smarter. I think we have, as a country, climbed a steep learning curve. We know the importance of physical distancing. We know the importance of wearing face coverings. We know the importance of stay-at-home orders. And so we have the tools in the toolbox. We've practiced them. Obviously, it's summertime. People are getting cabin fever and want to get out and relax them. But we know what we need to do to dampen down the person-to-person transmission. Closing schools was a big one. Could you imagine all those kids sitting in school classrooms and colleges and things? So we kind of have the playbook. We've always had the playbook, but in this case, we've been able to exercise and practice. So practice makes better. Doesn't make perfect, but it makes better. So I think that we'll know when it's time. Look, the cases are ticking up. Everybody will know the play in the playbook. Okay, that means we're going to have to stay at home. We're going to have to work remotely, homeschool, a lot of things we're going to need to do. So I think we'll be prepared, but time will tell.
Yeah. All right. All right. We're gonna be vigilant for all that stuff, I guess. All right. Let's go ahead and ask you this question, which is my favorite question from the list for you. Your opinion on reopening, Dr. LaMar, if it's too soon. And I gotta say that I checked the numbers this morning, and in the US, they just escalated dramatically. I don't know, it's just, there was a scary bar that just, it's almost like an outlier on the curve. And talk about that a little bit. Tell us your opinion.
Okay, so we just had Memorial Day weekend, which marks the unofficial beginning of the summer. Folks have been locked up and locked down for several months. Folks have been really, most states have been reopening since May 1. At this point in time, today is June, early June. At this point in time, every state has begun the reopening process. At this point in time, we're seeing cases either level out, maybe tick up just a little bit. Now, what you're referring to is there's been, over the last couple of days, some real big upticks daily upticks. So two things to put that into context. One, we just had Memorial Day weekend. A lot of folks wanted to get outside, and a lot of folks were doing things unsafely. In fact, I wrote an article about how to reopen safely in terms of enjoying the summer, enjoying your friends. So what happens is folks go out, they feel like the worst is behind us. They do all those mass gatherings and things that we tell them not to do. So I'm not surprised. I mean, I predicted that we'd have an uptick a few days to a few weeks after Memorial Day weekend, because folks just, they just went easy. They just took it easy and threw the precautions out the window. So that explains that. But when we're looking at the overall trend of cases, we're usually doing a 7-day average. So although there's been some huge spikes for a day and huge spikes for a day, unless that happens for the entire week for the most part, the overall 7-day average will continue to go down, and overall it's still kind of declining down. So we'll have to wait and see what's going on.
Yeah, got it. These couple of days that just passed are not an indicator, I guess, that it's a solid indicator until we see the 7 days.
That's right.
All right, that makes sense. Now, I read something you wrote on your LinkedIn, and which mentioned herd immunity. And I got to be honest, that was the first time I actually heard about that. And I think it's so interesting. Give us a little bit of information on that so that our listeners understand what herd immunity is.
Okay. Herd immunity, also sometimes called herd protection, is just in a simple way, it's the law of averages. And so what it's saying is that if, for instance, I was to go into a closed space, a closed room, and there were 10 people in that room, okay, and 8 of them were vaccinated or were immune because they already had the infection, okay? So that means that myself and the other person are vulnerable. But because the herd is vaccinated, there's not much person-to-person transmission, because if it hits somebody and say, oh, you're immune, I'm not going to infect you, I'm not going to infect you. So by being in that herd, amongst that herd of 80% folks who are really protected, it slows and protects the 2 that are there. Because my friend, let's say there's 2 of us, one is infected and the other one is not. So that one person can have interactions with 8 other people and not transfer that infection at all, and not have interaction with me, and I'll be good because I'm protected by the herd. I'm not immune, but the herd is protecting me. So it stops the chain of transmission. Okay, so herd immunity is a phenomenon where in a population, take the United States, if 80% of everybody in the United States either had the infection and got over it, or were vaccinated, again, same response in your antibodies, same protection you can get. It's called active immunity. Then the remaining 20% are going to be just fine for the most part, because everybody they run into, most of them are going to be already protected. So that's herd immunity. But the key thing about it is it will take about an 80% level, 75, 80% level to protect the rest of us. And right now, as you read in my short post on LinkedIn, we're probably somewhere in the neighborhood of 5% immunity, maybe 10% immunity. Some countries have said, you know what, just let the virus run wild, let everybody get it, interact, business as usual, and eventually a whole bunch of people that get it will have herd immunity and protect the rest. And that's a logical instinct in cases where the virus isn't as deadly. But this virus, has a death rate of 2, 3, 4, 5%. So there would be a lot of fatalities to just open the door and do nothing, And so that's the idea of herd immunity.
That is a great explanation, and I like it. I mean, I'm not sure if I want to open the doors to it, but maybe for other bugs, as you call them.
Right. But you can open the door for vaccinations. And if we had a vaccine, which we won't until over a year, if we had it and everybody went and got it, which doesn't happen either, because adults are about 4 out of 10 adults get vaccinations. Most people don't like vaccination. They love medicine. They hate vaccinations. I don't know if it's the shot or what, but they don't get vaccinated. But let's just say we had a COVID-19 vaccine, everybody took it, that would get our herd immunity up just as well as getting an infection.
That would be the answer why we need a vaccine. I mean, that's
Correct.
a secure and simple.
Correct.
If you have, I mean, I know there's light at the end of the tunnel, you know, but I always like to ask when I interview people or chat with people, can you give us some words that are positive and encouraging if it fits here for our audience?
Yes, well, I will say as an expert in medical epidemiology and in medicine, and as someone who has led health departments and led, responses to H1N1 and Ebola virus and SARS and MERS and things like that, we always get over it. So there'll be a time where COVID-19 will be a thing of the past. We'll probably add it to our seasonal vaccine. Once the vaccine is up, we'll add that piece to it and move forward. And so that's coming. But I will also say that we're going to have to start adjusting to what folks are calling a new normal in terms of trying to protect ourselves, not only systems that can predict when the next virus is coming so we can get an early warning and early alert, but also the way we do day-to-day interactions. You know, if it's handshaking, if it's getting a vaccine, getting our rates from the 40% up to maybe the 60%, 70%. Seniors do a lot better. About 6 out of 10 of them will get a vaccine. But if you're under age 50, I'm not in that group anymore. But if you're under age 50, your chances are 40% that you'll actually get the vaccine. So we got to change the way we do that. So maybe that's education. Maybe that's helping people understand the importance of vaccines. Handshakes and some of the greetings we do. Obviously, flu hygiene, which we preach all the time. Nobody really tends to pay attention. That is staying at home when you're sick. Stop trying to come into the office and suffer through it, getting everybody else infected. Hand washing, hopefully that will catch on. That'll be a new trend. Folks washing their hands and using sanitizer, gels and things like that, covering your cough. So if we keep those lessons going forward, get an early detection system for new bugs that are coming over, and do other precautionary things, I think we'll be better off for the next virus that comes. And it's not a matter of if, it's a matter of when it will be coming. COVID seems really bad now. At the end of the day, we'll probably lose, 250,000 lives here in the United States. We're up to, I think, 108,000 or so right now. Probably lose 250,000 by the time the dust settles, in my estimate. But if we take the lessons forward, I think we'll be a lot better off for the next epidemic or pandemic.
I think what I heard is that we're learning. And that's
we are learning.
We're learning and we're getting prepared. I want to thank you so much and invite you to join us maybe in the future when we have more topics. If you have the time, I know you're quite busy. I am going to continue to read your stuff. You're my favorite person to read. I want you to know that. And all of you guys that are listening, obviously invited to click on the links that I'm going to put up there for you and follow Dr. LaMar. So Dr. LaMar, thank you very much. You have a great day and we'll talk soon.
Okay, Frank, thanks for having me. Take care.